What would you do for someone vomiting blood? Hi, it's Dr. Fan here. Let's talk about haematemesis. Haematemesis is the hallmark feature of someone with an upper gastrointestinal bleed. Active haematemesis suggests a large volume of upper gastrointestinal bleed and is a surgical emergency. This suggests a major hemorrhage and is usually due to peptic ulcers or esophageal varices. There are a number of rarer causes, such as Cameron lesions from a hiatus hernia ulceration, marginal ulcers from an anastomosis of a previous bypass operation, Delafoy lesions from a large vessel running under the submucosa, and the dreaded aortoenteric fistula caused by an underlying aortic aneurysm. Other causes, such as gastritis and esophagitis, do not tend to cause large volume bleeds. Other signs of upper gastrointestinal bleed include coffee ground vomits and melena. In severe cases, a large volume upper gastrointestinal bleed with rapid transit can present with fresh perrectal bleeding, and it is an important consideration in assessing patients with hematochezia. History and examination is crucial in determining the likely causes of bleeding. Findings such as NSAID use, Helicobacter pylori infections, acute illnesses or other physiological stresses, and abdominal pains are more suggestive of peptic ulcer bleeds, whilst known cirrhosis, portal hypertension, and jaundice are more suggestive of variceal bleeds. Examination findings of tachycardia, hypotension, or even postural hypotension are suggestive of large volume bleeds. The standard set of bloods should be sent, including VBG, FBC, EUC, LFTs, coagulation profile, and cross-match. It is important to note that in acute bleeding, hemoglobin may not drop on the initial blood tests because there has not been sufficient time for the blood to dilute, and the concentration of the remaining blood volume remains the same. However, universally, lactate rises. This is due to the body switching to anaerobic respiration when tissues are ischemic due to hypovolemia. Urea also rises due to the digestion of globin proteins from the component of hemoglobin, which are then converted into nitrogenous wastes and urea. Meanwhile, deranged liver function tests and coagulation profiles suggest underlying liver disease and thus possible variceal bleeding. The distinction between peptic ulcer and variceal bleeding is important because it affects the management of the bleed. Initial resuscitation needs to be performed concurrently with the history and examination. This follows the A, B, C, D, E principles of resuscitation, with the main focus being on circulation. Large bore intravenous access and blood transfusions need to be established early. Patient outcomes are better with blood product resuscitation rather than crystalloid fluid resuscitation. Activate the massive transfusion protocol early if there are concerns of massive blood loss. See link below for video on massive transfusion protocol. Correct coagulation factors and reverse any anticoagulation. Of note, whilst tranexamic acid is often used for major bleeding, including upper gastrointestinal bleeding, there is no statistical significance in the outcomes of their use in upper gastrointestinal bleeds. Intravenous pantoprazole is also used for acid suppression and can be administered either as an infusion of 8 mg per hour or as a BD dose of 80 mg. There is no statistical significant difference in outcomes between the two methods of administration. If variceal bleeding is suspected, an octreotide infusion, prophylactic broad-spectrum antibiotics, and non-selective beta blockers such as propranolol should also be initiated. These initial management steps are important in stabilizing the patient, but ultimately the patient will require urgent definitive management, which is endoscopic hemostasis. The distinction between peptic ulcer bleeds and variceal bleeds is crucial here because peptic ulcer bleeds are managed by surgeons, whilst variceal bleeds are managed by gastroenterologists. With variceal bleeds, the patient will require variceal banding or sclerotherapy to control the varices. If there is a delay to intervention, or if the patient is too unstable to progress to intervention, a Sangsteigen Blakemore or Minnesota tube needs to be inserted. These tubes contain a gastric balloon, esophageal balloon, gastric aspiration port, and esophageal aspiration port. The gastric balloon is inflated first and placed on traction to pull up against the varices at the gastroesophageal junction. If there is still bleeding, the esophageal balloon is then inflated. Blood can be aspirated from the gastric and esophageal aspiration ports. This is only a temporizing measure, and the balloons need to be deflated every 12 hours and can only be left for a maximum of 48 hours to avoid mucosal necrosis. Ultimately, the varices will need to be treated with banding or sclerotherapy. Once controlled, the patient should also be referred for consideration of a transjugular intrahepatic portosystemic shunt, or TIPS, procedure, which diverts portal flow directly into venous drainage. This involves a transjugular catheter being advanced into a hepatic vein and through the liver into a branch of the portal vein. A stent is then deployed over the wire to create a portocable shunt to bypass the cirrhotic liver and reduce portal pressures. Let us now focus on surgical causes of bleeding, being from an ulcer. Ulcers can be classified using the Forrest classification, which stratifies the rebleed risks. Class 1, A, active bleeding, 90% risk. B, ooze from vessel seen, 10 to 20% risk. Class 2, A, non-bleeding vessel exposed, 50% risk. B, adherent clots, 30% risk. C, flat spot, 10% risk. Class 3, A, clean base, 5% risk. Ulcers can be treated endoscopically and need at least 2 modalities of treatment. These modalities include 1. Adrenaline injection. Adrenaline is a vasoconstrictor and can constrict the vessels supplying the ulcer and causes vasospasm and thrombosis, leading to hemostasis. However, using adrenaline alone is not sufficient because once the effects of adrenaline wear off, the ulcer may bleed again. When applying adrenaline, 10 mL of 1 in 10,000 adrenaline is drawn up and injected into 4 quadrants around the ulcer. Be sure to inform your anaesthetist when injecting because it can cause tachycardia and hypertension for the patient, but also your anaesthetists if you don't warn them first. 2. Energy device coagulation. Energy devices that can be used include the gold probe and argon plasma coagulation, or APC. These cause thermal coagulation through the formation of elastin and collagen crosslinks, much like with the use of diathermy. Gold probe is a diathermy device that converts electrical energy to heat energy to cause thermal ablation on contact. The rounded tip of the gold probe allows for a uniform contact and uniform thermal ablation of the ulcer. APC emits argon ionized by a high voltage of 6,000 volts along a tungsten wire, resulting in a thermal energy field around the probe. This is a non-contact method of coagulation that covers a large area of up to 2 to 3 millimeters deep. APC has the advantage of being able to cover larger areas more quickly than a gold probe, and also looks much cooler when being used. 3. Mechanical clips. Clips can be deployed over the scope or through the scope. Over the scope clips look like mini bear traps and are deployed from the tip of the scope to bite onto the ulcer. Through the scope clips are delivered along a wire and then deployed away from the wire once clipped onto position. These clips can be deployed on the ulcer to physically compress vessels that are bleeding. 4. Hemostatic agents. Hemostatic agents can be applied directly onto areas of bleeding. These come in powder and liquid forms. These agents are much like the hemostatic agents used as operative hemostasis adjuncts and will be covered in more detail in a future video. Even after dual modality treatment, there is a rebleed risk depending on the original Forrest classification and different methods of hemostasis used. If there is a rebleed, the second line treatment is to repeat endoscopy and repeat dual modality therapy. If the patient rebleeds again after 2 endoscopic attempts, then surgical intervention is required. This involves operative suture ligation of vessels around the ulcer. Most commonly, this will be a posterior duodenal ulcer in contact with the gastroduodenal artery. My approach to this management is a midline laparotomy, cockerize the duodenum by releasing lateral attachments, creating an anterior longitudinal duodenotomy, and suture ligation superior and inferior to the ulcer, in line with the gastroduodenal artery. Then close my duodenotomy transversely with 3 OPDS and then close the laparotomy. It is important to note that gastric ulcers are always suspicious for cancer. Biopsies should be taken if safe to do so. Otherwise, the patient needs to be booked for a repeat gastroscopy and biopsies once the bleeding has resolved. Thank you for watching. If you like this video, please like, share, subscribe, and comment for more videos.